I'm Michelle. I'm a research assistant at the London School of Hygiene and Tropical Medicine. And this project was conducted as part of the REACH team. So we investigated the impact of heat on maternal healthcare utilisation in Zambia using their health information system, so their routine data. So just for a little bit of background, so maternal and also neonatal healthcare indicators in Zambia fall short of some of the Sustainable Development Goals. And in part, that's because of the poor healthcare utilisation. So only 80% of women have a skilled birth attendant, and still 15% lack postnatal care within the 48 hours after delivery. There's also a low C-section rate compared to the kind of expected 10 to 15%. Now, climate change, as we can see here in the graph, for example, the rising temperatures, not pictured here, the flooding and the drought, are fully expected to exacerbate these access issues. There's a bit of an evidence gap at the moment, but there are emerging studies on the topic. So we set out with a theoretical framework based on the concept of kind of the supply and demand side factors. In terms of the demand side, we thought reduced mobility, within the heat, travel times, it might be hard to actually get to the facility if you're sitting on a hot bus or having to walk under the scorching sun. And then potentially also out-of-pocket costs, for example, for that travel, if their livelihoods have been affected by the extreme heat. Then from the supply side, facility closures might be an issue, staff absenteeism, power cuts and general disruption of services. And if we imagine that they might be sitting in, small cramped waiting rooms, and the waiting times might be high, the temperature will only exacerbate those issues. Okay, so our aims were to quantify the effect of heat, if any, and assess whether these effects differ across these service usage types. So we looked at 3 service usage outcomes: first trimester antenatal care visits, postnatal care within 48 hours of delivery, and also cesarean deliveries. And we obtained this data from the health information system, and we obtained this data as monthly counts. So we had to align the climate data to monthly counts as well. So we used monthly counts of hot days, and these were based on thresholds of the 90th, 95th, and 99th percentile relative to a reference period of 1992 to 2022, but we chose the 3 hottest months. So these thresholds are pretty high. Just to note that we did actually look at other exposure metrics as well, but ended up going with the hot days. Okay, so in terms of the study design, often in temperature studies, we can leverage either kind of spatial or temporal variation in order to find associations. And often that looks like a standard time series. So we'll have daily data, and then we'll track the health outcome and then the climate exposure over time. And then once you control things like seasonality, long-term trend, the idea is that you're left with the impact of that climatic event, heat in this case. Unfortunately, we have monthly data, so kind of in terms of the temporal variation, it's not so much, so we have to rely on spatial variation. So we used a variant called the case time series, and that accounts for multiple locations. One of the big strengths is that it's self-matched, so we are able to control for area level confounders like climate zone or healthcare that might differ between districts. So what we were doing in the model is comparing a district to itself. In this case, comparing a district to itself within each year and within each season. So we're seeing whether there may be any unusual heat events associated with a higher or lower incidence than normal within that period and district. Another thing that we did was we applied a distributed lag nonlinear model to one of the models looking at the C-section specifically, as we hypothesized that maybe earlier pregnancy or mid-pregnancy exposures might affect C-sections later on. Just to describe some of the graphs, because they are from a different study, but you'll see some similar graphs very soon. On the top right, we're seeing how the risk of an event changes with the lag. In this case, it might be days, but it could be months. It is months in our study, to a defined threshold. So here it's 22 degrees. And then on the bottom left, we're isolating a single month or lag 4 here, and we examine the range of temperature at that given time point. Finally, we used a population offset to model rates rather than counts, and basically that means we're standardizing counts by the number of births in a district, and so it becomes a rate model. And that leads quite well into our limitations, because you may be asking, why are we adding the denominator, the population at risk? Well, expected births can be highly seasonal, as we can see on the first graph. In the US, we see a really a seasonal peak in kind of August, September time. Now in Zambia, in the data that we had, we didn't observe as much of a seasonality, but it is still present, so we did need to account for it. Basically, we don't want to assume that an increase or a decrease of the outcome of interest, C-section, for example, was due to an increased number of births rather than the temperature. The second major limitation, and I kind of touched on this before, is the fact that we had monthly data. And so we're looking at counts of the outcome, counts of the exposure, and so we cannot assure the temporal sequence. We can't be sure that the exposure comes before the outcome, and that's just one of the limitations that comes with using this kind of data. Okay. Jumping on to the results. So first looking at cesarean deliveries, this first slide shows the cumulative exposure response, so the effective hot days of the entire pregnancy. The rate model's on the top, and then the count models are on the bottom. And we do see a suggestion that with increasing number of hot days, the incidence of C-section increases. However, coming from a statistical perspective, the error bars do overlap with 1, so the evidence isn't conclusive really for either of the two, the count or the rate models, top or bottom. There is a suggestion that there might be a bit of a dose response effect. So with increasing threshold, we see that the slope increases, the incidence increases. But yeah, we can't confirm statistically this at the moment. However, the picture changes slightly if we look at a lag on a lag basis. So what these graphs show is the changes when you look at one hot day. So what's the impact of one hot day? For example, lag 9 here would be, or lag 8 here would be 8 months before pregnancy. What's the impact of one hot day on that later incidence of cesarean? And again, we're seeing a little bit of a dose response here with the higher thresholds causing the greater impact. And we see about 0.5 to 1% increased incidence in individual months in early to mid-pregnancy. So lag 9 to 5 at the 99th percentile. And just, these do feel like small numbers, but it is per additional one hot day, so they do add up. Okay, in terms of antenatal care visits, we only looked at the month of the visit in this case, so we didn't look at previous months. And yeah, there's a potential decline, but the patterns are a little bit inconsistent and very wide error bars. So we concluded that it was probably not a true effect. And then finally, we looked at postnatal care within 48 hours. And again, we only looked at the month of delivery. So we see an initial slight increase in the risk of postnatal care or postnatal attendance. And then we see a marked decrease. In the case of the 95th percentile, from about 16 hot days, and then in the case of the 99th percentile, about 14 hot days. So basically what we're seeing is that there's about a 20% decrease with exposure to 20 hot days or more. Again, we're seeing this dose response with the steepening of the association with the higher heat thresholds. Okay, so what we concluded from our findings were that heat does impact utilization, and there is an element of heat intensity, so they're kind of heat intensity dependent. So the most confirmed finding is that postnatal care decreases, or postnatal care attendance decreases, and that is consistent with some other studies, although there aren't any. So in India, they looked at wet bulb globe temperatures, and they also saw a suggestive impact of higher thresholds. And then in Kenya, they included also some quantitative information, and there were two factors that came up. So maternal exhaustion after birth and heat, and also fear for the baby's safety. And it's important, of course, as in postnatal care, is important, of course, to reduce maternal complications. So this is a quite adverse finding. We didn't find impacts on antenatal care, however. Potentially behaviorally, in the first trimester, pregnant women were able to carry out routine activities, but of course this needs to be studied. That being said, we should not be complacent about early exposures, given what we found about cesarean deliveries and that early heat exposure impact in the first trimester. So potentially complications like hypertension may develop in early pregnancy, but require later intervention. And then what are some of the implications and recommendations from this? Firstly, the information that we got from the health system was incredibly valuable, and it could be further used to integrate heat warnings. And so there has been success in Zambia with the visualized malaria with and local facility decision making with regards to the DHIS2 climate dashboards. Another thing is denominators are, of course, good to have in pregnancy research, and so is daily data, but that's not always possible. And it's kind of, I guess it's a bit of a tale not to be dissuaded to look into this data anyway, because we're getting more information and we need more information from these contexts. So this is a bit of a stepping off point. We need more information, especially the qualitative information about the pathways behind these patterns. And then finally, in terms of the policy responses, we could suggest greater operating theatre readiness in hot months, extended hours, shaded areas for waiting, water availability, things that people have already raised thus far. And ultimately, so it would be that Zambia's National Adaptation Plan did not mention heat or maternal child health for the last iteration in 2024, I believe. And so we're campaigning to get it into the next one. So let's see how it goes. And so, yeah, just a huge thank you to, firstly, the REACH team, and secondly, also the conveners for inviting me to present. I look forward to questions soon, but just in case, here's my email address. Thank you very much.
Thank you.